My topic today is a comparative study of Widefield ICG angiography in pachychoroid diseases, no financial interest or conflict of interest. As we already know, pachychoroid disease includes choroidal thickening with dilatation of vessels in the Haller's layer and attenuation of vessels in the Sattlers and the choriocapillary layer. So what the study primarily concerns is about what causes the pachychoroid phenotype and why the same pachychoroid phenotype gives rise to different clinical manifestation. So the spectrum includes PPE, that includes, along with other pachychoroid features, there are RPE defects, CSCR where there is neurosensory detachment, PNV where there is type 1 MNV, and in PCV there is aneurysmal type 1 CNVM. So this was a study for choroidal vasculature changes in pachychoroid diseases using Widefield ICGA. It was a cross-sectional observational study with institutional ethical committee approval. The clinical examination was done and OCT was used for the diagnosis, where the subfoveal choroidal thickness was taken to be 350 microns, and other than that, all other features of pachychoroid disease as discussed earlier. And any patient with prior treatment or inflammatory choroidal conditions were excluded. Widefield FFA ICGA was done on Mirante, and analysis was done by 2 independent observers. As a result, we found there was a male preponderance with a mean age of about 40 years, and there was 15 neovascular PCD and 25 non-neovascular PCD. Most of the patients had vision better than 618. This graph shows that the neovascular PCD predominantly had macular polyps, and in non-neovascular PCD, the most commonly seen patients were of chronic active CSCR. These are the prototype case where we see the acute CSCR with SRF and ink blot pattern leakage with NSD on OCT with pachychoroid vessels. This is a chronic CSCR where there is gravitational tract with classic teardrop sign and RP defects seen on the OCT. This was a apparently normal looking fundus with a few microaneurysm and a pachydrusen seen in the OCT. Then this was an exudative maculopathy where we saw the late leakage and staining seen with tall notched PEDs. So this was a normal vortex vein distribution where we see that the vessels are almost of the normal caliber, similar caliber with a normal watershed zone maintained. But in our cases, we found cases with asymmetric vortex vein distribution where one or the two vortex veins drained more part of the choroid rather than the other. And it was identified in early phases of the angiography. Dilated vortex veins were seen in the early phases. Then the posterior extension of those dilated vessels were seen towards the peripapillary region or macula or both. And intervortex anastomosis was seen as the loss of physiological watershed zone, and it is suggestive of vascular remodeling. Then choroidal vascular hypopermeability was seen and identified in the mid to late phase of the angiography, which correlated with the dilated vessels or intervortex anastomosis, and correlated also with the leakage and the window defects on FFA. So this is the table showing that CVH was seen in almost all cases of chronic as well as acute CSCR, with vascular remodeling seen more in the cases of chronic active cases, and neovascular pachychoroid disease mostly had patients with intervortex anastomosis. So because of the choroidal vessel alteration in the periphery, which slowly gets the vortex vein dilated and extend towards the posterior pole with intervortex anastomosis, there is excessive flow, and that causes RP damage that is more pronounced in cases of chronic active cases, and it tends to ebb away in resolved cases. So what we already knew is about pachychoroid is this, and because of all the studies done outside India, where we see that there are many choroidal vein alterations seen and classified, our study adds to that chronic active PCD has congestive choroidal changes as the global problem, and increased instances of intervortex anastomosis was seen in neovascular PCD that suggests that the congestive features are ebbed away, but the RP damage and oxidative stress becomes the trigger for the neovascularization. So this could help to understand and monitor the treatment provision and streamline the treatment protocols, and also subthreshold laser can be used in distended veins and intervortex anastomosis, and targeting dominant veins in cases of surgical procedure if we go for. The limitation of our study was about the study population, so a multicentric study with large number of cases would be beneficial. Subjective studies or standardization would increase the objectivity of the study, and ICG at successive follow-up could help us in monitoring of the disease. Thank you.
So I just saw in one of the slides you mentioned opening of the scleral window to relieve the congestion, as one does so often in uveoscleral increased outflow disease like nanophthalmos, yeah, the sclerectomies. So you're suggesting a similar procedure for this?
It could be planned, sir, but it could be planned for.
Yeah.
It can be planned for such, but generally we don't go for the surgical options in cases of PCD, and because we have better options with like relatively lesser invasive forms.
You're right, because the choroidal thickness was the main center of attraction previously. Now we are going towards
The vascular
the choroidal flow disturbances, and scleral thickness is also coming up as another additive
Yes.
factor.
In uveal effusion syndrome, the scleral thickness is high, but CSR, it's controversial.
Yeah,
It's-
pachychoroid, in
yeah.
terms of pachychoroid spectrum, some people are.
Yeah. There is a theory of thickened sclera and CSR as well. Thank you.
Thanks.